Hey guys, video is recorded on the 4th July 2017. Okay, so today we're going to talk about pterygium. Okay, so for your information, pterygium is a degenerative condition affecting the conjunctiva. Okay, now just to let you know what are the other degenerative conditions. Okay, degenerative conditions. Right, we have pinguicula, if I'm pronouncing it right. Okay, obviously pterygium is one of it also, and concretions. Okay, so we're going to discuss today about pterygium. So pterygium happens to be a degenerative hyperplastic condition. Okay, important, you need to note it is hyperplastic, right? Plastic condition. Okay, now just looking at the word pterygium, right? This word pterygium actually derived from a Latin word. Okay, this word pterygium is basically from a Latin word called pterygion. Okay, which literally means wing. Okay, so basically pterygium, right, is a wing shaped fold of conjunctiva. Okay, a wing shaped fold of conjunctiva. Okay, so you can draw some wing. Okay, let's say this is a wing. Okay, so it's basically a wing shaped fold of the conjunctiva. Okay, so how that wing shape comes about? Due to the degeneration that takes place, and that degeneration happens to be also hyperplastic in nature. So as it degenerates, right, it's going to deposit something, right? So we'll see that in a while. Okay, that's the pathology of it. We'll look at it. So, but basic idea of pterygium, it comes from a Latin word pterygion, which means wing. So it's a wing shaped fold of conjunctiva, literally. Now it's a degenerative hyperplastic condition. So these are three things we need to note: 1, 2, and 3 for pterygium, right? Now, what are the features of the pterygium? As you can see on this image, this pterygium commonly happens to happen on the nasal side. Okay, can you see on the side? If you can appreciate it from this picture, can't really see it, but yeah, on the side of your nose, it happens to be triangular. Okay, that wing shape happens to be triangular. If you can appreciate this here. Okay, triangular. At times it is unilateral, and at times it is bilateral. So these are three important things: nasal side, it is triangular, unilateral, bilateral. And one important thing, the arrow pointing here, this line here, I'm not going to remove that, okay, because it's already pointed. That line is called Stocker's line. Okay, so what is this Stocker's line? Right, Stocker's line is basically iron deposits. Okay, iron deposits on the corneal epithelium. Obviously, as you can see, this is the cornea. So on the corneal epithelium anterior to the head of the pterygium. Okay, what is the head of the pterygium? Right, obviously you're going to ask, right, because I just said anterior to the head of the pterygium. So basically the pterygium has got three parts. Okay, three parts: the head, okay, the neck, and the body. Okay, so this is the triangle. See, most of the time it is nasal side, as you can see here. So this, I think from this picture you can see, right, it is triangular. Okay, now obviously you can't appreciate whether it's unilateral or bilateral in this picture, and there is no Stokes line, but see, now the head is any part. See, if I'm drawing this as a conjunctiva, cornea, right, a complete cornea, right? So whatever that is here that I'm shading now is your head. Okay, anything on the cornea is your head. Then let's use a different color. Anything on the limbus, okay, and just try to imagine that's your limbus, is your neck. And balance whatever you see, right, that is your body on the conjunctiva commonly. This conjunctiva sclera basically, right, on the sclera, lying on the sclera, because it's the fold of conjunctiva lying on the sclera. Okay, so that means, right, something that I should have mentioned in the first slide itself, this fold of conjunctiva, right, as we saw here, wing-shaped fold of conjunctiva, right, it encroaches or gets onto the cornea, right, it moves, that means it grows onto the cornea, right, so blocking the pupillary area, just to let you know, right. I hope you understand it, right. So there are two types of it: progressive pterygium, regressive pterygium. So when I say progressive, obviously your understanding is it grows, encroaches the cornea, right. Now as it encroaches the cornea, it blocks your pupillary area. Okay, now you need to know how to differentiate between a progressive and regressive pterygium. How I think of progressive is like meat. Okay, it happens to be fleshy, very thick, and vascular. Okay, this is how I look at progressive: fleshy, thick, vascular. So regressive is just the opposite. It would be atrophic, very thin, and less vascular. Now at times, right, the progressive pterygium, there is a cap. Okay, this cap is present anterior to the head. Okay, anterior to the head, that means in front of the head. On the other hand, there is no cap here on the regressive one, right? So that covers type. So it's understood, right? What are the main features? What are the parts of it? And what are the types? Okay, now moving on to the etiology, it's exactly not known, right, but it's observed. Okay, it's very common. It has environmental origin, obviously. Okay, very commonly whenever there is dust, a lot of dust, right, whenever there's a lot of dust, what happens, you can maybe say, the dust particles gets lodged, and this triggers this degenerative hyperplastic condition, right? That is one way you can look at it. What is that? Accompanying this dust, right? Winds, high winds, right? High wind. Okay, clear? These are very common condition. And dry heat. And also exposure to sun. Okay, also observed. Now what is the pathology? So yeah, roughly we know it's dust, wind with heat and sun causing this pterygium, right? So, but how these things can cause? So as we saw, it's a degenerative hyperplastic condition. So maybe this environmental factors trigger this degenerative condition, so what happens is there is going to be degeneration. Okay, there's going to be, let me check a pen. So there's going to be a degeneration. So degeneration, but at the same time this degeneration is hyperplastic in nature. You have to understand these two words. I keep saying this, uttering, because that tells you the pathology. So degeneration, what type of degeneration? There's going to be elastotic degeneration. Okay. Now this elastotic degeneration, so what do you mean or understand by this elastotic degeneration? That means as it degenerates, right, there is going to be accumulation or deposition, you can say, accumulation or deposition of elastin or elastic tissue. And commonly this happens, right, when there's exposure to sun, heat. So it's more common in this condition, hot climate basically, seen in people with living in hot climate. Okay, so what, so commonly seen when there is extreme or prolonged sun exposure, right? That is the degenerative part or degeneration part. Then why I say hyperplastic also is important, because at the same time as it's undergoing elastotic degeneration, right, where elastin gets deposited, or elastic tissue in other words gets deposited, that means as it degenerates, elastic tissue gets deposited, there is also going to be proliferation. Okay, right, and this proliferation will be in the form of granulation tissue, highly vascularized granulation tissue. So the word vascularized tells you, see, vascular, it's very vascular, right? Progressive pterygium, extremely vascular. Okay, so this is what happens, right? There is going to be degeneration first, and then it's going to proliferate also, right? This then, right, this degenerative hyperplastic condition, yes, is going to lead to, a minute, let me just change this layout. Yeah, so that's easier for me to write. Okay, so whatever happens, right, is going to result in damage or destruction of the normal oh, I forgot to tell you this. Then this obviously encroaches the cornea. Okay, that's important. Let's write that down here also. I keep forgetting this. It's important now, this encroaching the cornea. It encroaches the cornea very importantly. So encroaches the cornea, this thing, then yeah, it causes destruction of the normal corneal epithelium, the first three layers of cornea basically. Okay, the Bowman's membrane and the superficial stroma. Okay, so that covers your pathology, pathogenesis, anyhow you can say it. Okay, so you must get the word down, degenerative hyperplastic. So if you remember the two words, you can understand the pathology. So what is the symptoms? Now most of the time, if it doesn't reach up to the cornea yet and doesn't block the pupillary region or area, it is commonly asymptomatic. Yes, it's asymptomatic, but yeah, ugly. So cosmetic intolerance is there. Asymptomatic, but yeah, it is ugly. But over time, as it encroaches the cornea and covers the pupillary area, so as it encroaches the cornea and covers the pupillary area, you are going to get visual disturbances. Okay, clear? And then after some time you also get diplopia, double vision. Now why this double vision results is very simple. What happens, right, as there is what deposition happening, right? So it starts affecting your ocular movement. Okay, so this limited ocular movement gives you the diplopia. Okay, clear? So differential diagnosis. So we normally diagnosis of pterygium is basically on the clinical features. Okay, these are the complaints patient is going to come with. Patient is going to say there's some ugly patch on the eye, right? So I'm just trying to give you an example. So patient is going to come, is going to say there's some ugly thing on the eye in early stages, and then over time he's going to say I'm having problem in visualizing things, and after some time more he's going to say I'm seeing double, right? So that's the complaint, and normally as you see it as a clinician, as you see it, you're going to know it's pterygium. But when or how are you going to differentiate it from other thing that can happen or looks the same? That is pseudopterygium. Okay, that's your differential diagnosis. So sometimes it might be pseudopterygium. Now, what is pseudopterygium? That's important. Now, it is basically bulbar fold of conjunctiva. Fold of your conjunctiva that happens to attach. Okay, attach to cornea. Okay, bulbar fold of conjunctiva attached to cornea. Now commonly why this happen, right? Why does this bulbar fold of conjunctiva gets attached to cornea is because there is chemosis. Okay, in many conditions there are chemosis, and whenever the cornea has what is that? Ulcer. Okay, corneal ulcer. So what happens, right, is this chemosed part, chemosed bulbar fold of conjunctiva, right, this swelled up area gets attached to the corneal ulcer. Okay, clear? Now, so obviously there are some features, I'm just going to go through them here. Okay, now as you can see, pterygium happens commonly, look at the age group, in elderly. Okay, whereas on the other hand, if you look at pseudopterygium, it can happen anytime. Anytime you get a corneal ulcer and there's chemosis, there's going to be attachment of the bulbar fold of conjunctiva onto the cornea. So pterygium normally on the palpebral region, pseudopterygium happens at any site. Pterygium happens to be a degenerative condition. This pseudopterygium is inflammatory, right? Inflammatory in the sense that it's an ulceration, right? That means it's an infective keratitis. So that infection, right, gives rise to an inflammation. Clear? So that inflammation then leads to this attachment of the bulbar fold onto the corneal ulcer. Chemosed bulbar fold on the corneal ulcer. Now stages with pterygium, it can be progressive, regressive or stationary. On the other hand, pseudopterygium can never progress or regress, because just think of it, it's something that was there, just gets attached to the cornea. Okay, and on probing, normally probe doesn't pass underneath the pterygium, but it passes under the neck in case of pseudopterygium. Okay, that brings us to treatment then. Now the only way it can be treated, best method of treatment would be surgical excision. Okay, that is the best. Now normally when do you do surgical excision? Okay, when do you decide, fine, I'm going to do surgery? Now most of the time, if it doesn't affect the vision, you don't do it, right? But sometimes some people don't like it. It looks ugly. So whenever there's cosmetic intolerance or for cosmetic reasons, then yeah, that's the first reason normally people do surgical excision. Okay, for cosmetic reasons. Number two, let's say there is going to be visual disturbances. Now, visual disturbances, it can be in the form of is there already, or prophylactically, as you see the pterygium growing, right? As you see the pterygium growing, you're going to do the surgery, because what happens, right, if the pterygium is already on the papillary area, right, you cannot perform the surgery. You got to let it cross over to the other side, then only you can perform surgery, right? So when you know, okay, it's already growing, that means progressing, perform the surgery. Okay, don't let it, encroach the papillary area, because if it encroaches to the papillary area, you have got to wait until it passes to the other side. Okay, let's say this one, then you see the pterygium is growing, you see it coming here already, you perform the surgery. Don't let it get onto the papillary region. And obviously diplopia. So basically your symptoms, whenever you see any of your symptoms, then you're going to perform the surgery. So we're going to look at the surgery now. So how are you going to perform the surgery? Number one, you're going to give topical anesthesia, right? Okay, obviously it's best to view videos, so do watch. There is videos on YouTube on pterygium excision. Do watch it, but I'm just going to go through the steps step by step. So you give topical anesthesia, you're going to clean the eye, drape it, and expose, right, the eye. Then what are you going to do now? As you can see in picture A, lift pterygium up, okay, from the cornea. Okay, so you lift it up already, and then so hit at that lift hit of pterygium up from the cornea, then start dissecting slowly, very carefully, very meticulously dissect. Then so from the cornea you dissect it in this first picture, as you can see. Then you see you're progressing this side, right? That means onto the limbal area, then that means where your neck is, then go on to the body that's on the sclera. Now what happens? So dissect first the head, then you continue dissection, right, from sclera. Okay, now what happened after that? Obviously there's going to be bleeding. Okay, so what you're going to do is hemostasis, obviously achieved by cauterization. Okay, where whatever episcleral tissue that is here, okay, if you can see where I'm coloring that underneath layer, so exposed episcleral tissue cauterized. Okay, done. So that means you have already removed the pterygium. Right now there are a few methods after that, thereafter, right? Now that is important. So there are a few techniques. So let's look at the techniques. So what are the techniques? if you look at this picture, see here, this is the first technique. I did a simple excision. Okay, so what do you understand by simple excision? That means I'm going to remove the pterygium as whatever I've stated here, right? Just removing this wing shaped fold of conjunctiva, right? That is what you do first, and then just, so I'm just writing, I'm going to write remove as above, then suture the conjunctiva to cornea. That's it. As you can see there, I sutured the conjunctiva back to the cornea. Done. Simple, right? So simple excision. Number 2, D. If you can look here, this region here, I left it bare. Can you see this, whatever I'm trying to color here? Okay, in green. So this is called bare sclera technique, right? That means I'm going to remove, as usual, right, the pterygium here, then some part of conjunctiva I'm going to also remove. Okay, so part of conjunctiva also excise, right? And then whatever edge here, right? Can you see the edge? If you can see where I'm pointing, let me, right? Okay, where I'm pointing. Okay, so that edge is then sutured, edge sutured to the underlying episcleral tissue. Episcleral tissue. Okay. Okay, so we covered 2 techniques already. Simple excision, that means I just remove and then I just suture the conjunctiva back to the cornea, right? Then bare sclera, I remove, then I'm also going to remove part of conjunctiva, so there's, you know, this bare area, right? Then whatever edge is there, I suture to the underlying episcleral tissue. Now next method is this picture E. Okay, so in this picture, as you can see, right, there is some pink stuff, right? So what is this pink stuff? This pink stuff is actually a graft. Okay, yeah, there's a graft. So there are 2 graft methods. Okay, so the first one is free conjunctival graft. Okay, now this graft, I can take it from that same eye or from the opposite eye. Okay, so this graft, right, would go on to cover bare sclera. Now this technique is very useful because it reduces recurrence. Now with pterygium excision, especially with the first method, right, simple excision, there is high recurrence rate. So with this bare sclera method and also this graft, usage of graft, you actually decrease recurrence. Okay, that is the advantage. Now another graft method, so the first one, free conjunctival graft, either, as I told you, from the same eye, opposite eye. Next, limbal conjunctival. autograft transplantation. Okay, clear? That's another technique also to cover whatever you have excess, right? So these are the two graft techniques. Now, see, as I told you, recurrence rate is very high. So how are you going to reduce recurrence? So you have to use two important techniques, as I said, right? Your surgical techniques, choice of surgical techniques can decrease recurrence tremendously, right? So the choice would be, I would prefer to, if I want to reduce recurrence, right, is the bare sclera technique, graft technique. Okay, normally the free conjunctival graft, right? So you can write that down, bare sclera. So surgical excision with bare sclera technique or graft technique, especially the free conjunctival graft, right? These are the two common techniques useful. Okay, also you can, okay, another way to reduce is post-op application of antimitotic drugs. Such as mitomycin C. Okay, such as mitomycin C. Now let's say, fine, I've already done it with these two techniques, but still I have got a recurrence, and with a recalcitrant pterygium. Okay, this pterygium that's very stubborn, not getting off, coming back repeatedly. So if I got a recurrent recalcitrant pterygium, keeps coming, very stubborn, then what am I going to do? Right, I'm going to do surgical excision, and together with the surgical excision, okay, I'm going to do lamellar keratectomy and lamellar keratoplasty. Okay, lamellar keratectomy, okay, I've got always a problem spelling this word, keratectomy. Okay, let me just pronounce it, keratectomy. And keratoplasty. Okay, clear? Now there are older methods, right, such as post-op use of beta irradiation or Mac-Reynolds operation. Not performed nowadays, I'm not going to write that down. Okay, these are older methods, post-op use of beta irradiation and Mac-Reynolds operation. You can note it down if you want, but not so important. Then moving on to complications, obviously it is very simple. The first thing that can happen would be infections only you got to worry about. Sometimes, yes, you do get cystic degenerations, okay, so that covers your pterygium. Okay, done with pterygium. So I'm just going backwards now. So we saw the complications first, how you want to reduce recurrence, what are the techniques, important surgical techniques, how you perform the surgery, right, then the two types, right, and how you differentiate them, what is pseudopterygium, what are the symptoms, what is the pathology, okay, what is the etiology, the types we saw, progressive, regressive, parts, the three parts, the head, neck, body, important features, and what is pterygium, right? So thank you for watching, hope you understood.